Now we are going to learn something about pneumonia. Pneumonia is an inflammation of the parenchyma of the lung. Most common causes of pneumonia are caused by microorganism. Non-infectious causes include aspiration of food or the gastric acid, foreign bodies, hydrocarbons, and lipoid. So look in this picture. Uh, there is an anatomical structure of the respiratory system in which we can easily think. Actually, the picture is not clear, so I will not go into the detail of the things. So, pneumonia. What is the classification of pneumonia? Classification, anatomical classification is lobar pneumonia, the consolidation in which the consolidation involves all of the part of the lobe. B is bronchopneumonia. The consolidation involves the scattered lobules. And says interstitial pneumonia, as in the viral pneumonia, where inflammatory pathogens are responsible. Pneumonia. Again, the etiological classification. The cause of the pneumonia in patients is often difficult to determine because direct culture of the lung tissues invasion rarely performed. Culture obtained from the upper respiratory tract or the sputum generally not accurately. Cause of infectious pneumonia, like bacterial, commonly Streptococcus pneumoniae. Group B Streptococcus is responsible for the cases. And Group A Streptococci, Mycoplasma pneumonia, Chlamydia pneumonia, Chlamydia trachomatis. Chlamydia pneumonia mainly in the adolescent, and Chlamydia trachomatis is mainly in the infants. So uncommon causes are like uncommon bacteria, Haemophilus influenzae, mainly in the unimmunized person. Staphylococcus aureus, Mourya catarrhalis, and Neisseria meningitis, Fancicella tularensis, mainly in the animal fly contact. Nocardia species, mainly in the immunocompromised persons. Chlamydia sticky in the bird, mainly in the contacts, but person contacts with the birds. Bird pneumonia, viral, common respiratory syncytial virus, parainfluenza type 1, 2, 3, influenza A, B, adenovirus, metapneumovirus. Uncommon like rhinovirus, enterovirus, herpes simplex, enterococcus virus, mainly the neonates. Herpes simplex is also in the neonates. Some fungal causes of pneumonia like histoplasma capsulatum, mainly in the bird-bat contact. Cryptococcus neoformans, mainly with the bird contacts. Aspergillus species, mainly in the immunosuppressed conditions. Mucormycosis in immunosuppressed conditions. Coccidioides, emitis, and blastomyces dermatitis. And mycobacterial causes like Mycobacterium tuberculosis, mainly in the developed countries. Mycobacterium avium intracellular, and mainly in the immunocompromised patients. Parasitic like pneumocystis carinii, mainly in the immunosuppressed, and mainly the steroid-induced immunodepression patients. Eosinophilic like Ascaris and Lafleur syndrome. Some non-specific infectious causes like aspiration of food and the gastric acid and the aspiration of the foreign body. So pneumonia, according to the age group, neonates less than 1 month. Group B, Streptococcus is mainly responsible. E. coli, Streptococcus pneumonia, like H. influenza. 1 to 3 months of febrile pneumonia, RSV influenza virus, parainfluenza virus like adenovirus, S. pneumonia, H. influenza, F. febrile pneumonia, Chlamydia trachomatis, Mycoplasma hominis, cytomegalovirus. 3 to 12 months, RSV influenza virus, parainfluenza virus, adenovirus, S. pneumonia, H. influenza, Chlamydia trachomatis, Mycoplasma, Pneumonia, Group A, Streptococcus pneumonia. 2 to 5 years of age group, influenza virus, parainfluenza virus, adenovirus, S pneumonia, H influenza, mycoplasma pneumonia, and chlamydia pneumonia. Hospitalization of children with pneumonia, if age is less than 6 months, sickle cell anemia with acute chest syndrome, multiple lobe involvement, immunocompromised, toxic appearance, severe respiratory distress syndrome, requirement of supplemental oxygen, and dehydration. Recurrent pneumonia is a hereditary disorder like cystic fibrosis, sickle cell disease. Disorders of the immunity like AIDS, Beton, agammaglobulinemia, selective IgG subclass deficiencies, common variable immunodeficiency syndromes, severe combined immunodeficiency syndrome, and disorders of leukocytosis. Disorders of the cilia, immotile cilia syndrome, Carter syndrome, anatomic disorders like sequestration, lower emphysema, esophageal reflux, foreign body, tracheoesophageal fistula, gastroesophageal reflux, and bronchitis. The pathogenesis, the lower respiratory tract is normally sterile by physiological defense mechanism including mucociliary clearance, properties of normal secretions such as secretory immunoglobulin A, like IgA, clearing of the airway by coughing, immunological defense mechanism of lung limit invasion by pathogenic organisms, includes macrophages are present in alveoli and bronchial secretory IgA and other immunoglobulins. So here we can easily see like how the pneumonia in the patients are present with us in the normal routine practices, like systemic high fever with chills and rigor, with chills and skin, in case skin, the calmness of the skin and blueness of the skin, you can see easily. If the lungs are involved and the lungs are mainly involved, but the symptoms are like cough with sputum or shortness of breath and pulmonary chest pain, cough mixed with blood means hemoptysis. In case cardiac high heart failure, gastric like nausea, vomiting, IBD like symptoms, vascular like low blood pressure, and central nervous system like some symptoms like headache, loss of appetite, and mood swings. These are the main characteristic features which we are found in our day-to-day practice in our patients of pneumonia. Viral pneumonia usually results from the spread of infection along the airway, accompanied by direct injury or direct injury or respiratory epithelium result in um, airway obstruction from swelling, abnormal secretion, and cellular debris. A small caliber of the airway in young infants make them particularly susceptible to severe infection. Viral infection predisposes to secondary bacterial infections by disturbing the normal host defense mechanism, altering secretion and modifying bacterial flora. Bacterial infections. In bacterial infections, pathologic process varies according to the invading organisms. Mycobacterium pneumonia attaches to the respiratory epithelium, initiates bacillary action, and lead to cellular destruction and an inflammatory response in the submucosa as the infection progresses. Slurped cellular debris, inflammatory cell, and mucus causes airway obstruction with spread of infection occurring along the bronchial tree as in viral pneumonia. Group A, Streptococcus pathology includes necrosis of tracheobronchial mucosa, formation of large amount of exudate, edema, and local hemorrhage with extension into the interalveolar septa and involving of lymphatic vessels and pleura. As aureus pneumonia produce toxins and enzymes as hemolysin coagulates and staphylokinase. It causes bronchopneumonia, often unilateral, characterized by the presence of pneumonia bacteria. Following changes stages, first, second, third, and fourth. There are four stages mainly. First is congestion alveoli are filled with edema, fluid, and organisms. Radipidization, alveoli contain polymorph RBCs, fibrin edema, and organisms. Grapidization, diffusion of fibrin over the pleural surface phagocytosis starts inside the alveoli, which are now filled with polymorphs and fibrin. Resolution stage, neutrophil degenerates fibrin thread and remaining bacteria for digested and removed by phagocytes. Clinical manifestations, in case clinical manifestations, viral and bacterial pneumonia are often preceded by several days of symptoms of urtia, typically rhinitis and cough. In bacterial pneumonia, suddenly shaking chills, followed by fever, cough, grunting, chest pain, drowsiness, rapid respiration, dry cough, anxiety, and circumvental cyanosis. What we are finding as in physical finding in a case depends on the stage of pneumonia, diminished breath sounds, scattered trickles and rhonchi over the affected lung, increased consolidation of or complication as effusion, empyema, or pneumothorix, dullness on percussion and breath sounds, diminished abdominal distension because of gastric dilatation or from swallowed air or ileus, abdominal pain in lower lobe pneumonia. Diagnosis: how will you diagnose the case of that? This is a case of pneumonia with the other respiratory tract disease. In case chest X-ray, diagnosis of pneumonia may indicate complication, pleural effusion, or empyema. Viral pneumonia X-ray, hyperinflation with bilateral interstitial infiltrate pneumonia, lower consolidation. Viral pneumonia X-ray, and then repeat chest X-ray are not required for proof or cure for the patient with uncomplicated pneumonias. So, chest X-ray of pneumonia mainly indicated in complication of the pleural effusion or empyema. So, repeat chest X-ray are not required. Uncomplicated pneumonia, WC can differentiating viral from bacterial in virtual WC normal or elevated, but usually not higher than 20,000 per millimeter cube. With lymphocyte predominance elevated, bacterial 15,000 to 40,000 predominance lymphocyte, perfusion, lower consolidation, and high fever at onset of illness suggest of bacteria. So, what about the treatment of pneumonia? Treatment based on cause and clinical appearance of child. Children do not require hospitalization. Amoxicillin 80 to 90 milligram per kg 24 hours. Cefuroxime for school age children with microbial pneumonia, C pneumonia, atypical pneumonia, macrolide antibiotics such as azithromycin, bacterial pneumonia in hospitalized child, cefuroxime in a dose of 150 milligram per kg 20 hours, cefotaxime is called clefairan, ceftriaxone. If stable pneumonia, then we are using high broad spectrum antibiotic. Deterioration in clinical status, antibiotic therapy should be initiated. Response to treatment: patient with uncomplicated pneumonia respond to therapy with improvement in clinical symptoms like fever, cough, tachypnea, chest pain within 48 to 96 hours. Slowly resolving pneumonia, like complication of pneumonia. Second is bacterial resistance. Third is non-bacterial etiology of virus and aspiration of foreign bodies or food. Bronchial obstruction from endobronchial lesions, foreign body of or mucus plug. Pre-existing disease such as immunodeficiency, celiac dyskinesia, cystic fibrosis, pulmonary sequestration of cystic adenomatoid malformation. Non-infection causes bronchial obliterans. Complications of pneumonia such as usually result from the direct spread of bacterial infection with thoracic cavity, effusion, empyema, pericarditis, of bacteria and hematologic spread, meningitis, supportive arthritis, osteomyelitis, in which, like we see in the X-ray pictures of some of the pneumonia, in which we are seeing that in the first picture there is mostly हम लोग गड़बड़ ये कर जाते हैं कि we can see that we can it is that mainly the bronchoalveolar prominence is there, so it is not very much clear in this picture. But in the second picture, we are seeing that there is a consolidated patch in the right upper lung fields, and in which we are easily seeing the non-homogeneous opacities in the right side of the X-ray. And if you correlate clinically with the lab investigations, if the diagnostic criteria fulfilled, then we can say that this is a chest X-ray of pneumonia. In third X-ray, we are easily recognize that there is a pictures of infiltrated lesions in both sides of the lung fields with there is a cardiomegaly. Actually, this is not clearly picture of cardiomegaly, but we can see in the hilar region there is infiltration, white fatty spots, and we can see the easily opaque lesions here. In the fourth X-ray also, we can easily see that the bilateral lung fields are involved in a case of pneumonia. So I think that mainly in the COVID patients, which is recently was we have suffered from. In that case, mainly the patient is suffering from the COVID infection, but the clinical features of the respiratory systems are involved at that time. If we go through the CT scan and the X-ray, then we easily find that there is involvement of the respiratory lung fields, and the most common cause of death in that case also is due to pneumonia. Pneumonia involved into bilateral involvement of the extensive involvement of the lung fields, and the RDS-like pictures is there. So now I think that you can easily judge according to the symptoms of pneumonia and the lab parameters. So now my next topic, I want to say you something about hepatorenal syndrome. So hepatorenal syndrome, what do you mean by hepatorenal syndrome? I will tell you about the hepatorenal syndrome. Introduction to the revised American Association for the Study of Liver Disease Practice Guideline, management of the adult patients with ascites due to cirrhosis. So, hepatorenal syndrome pathophysiology, diagnosis, and management. And by definition, now I have come to the definition of the hepatorenal syndrome. Chronic or active liver disease with failure plus portal hypertension. Acute kidney injury result in creatinine 0.3 milligram per dl in 48 hours, or 50% rise in 7 days, or rise more than 1.5 milligram per dl. With no shock, no nephrotoxic drug usage, normal kidney size, no other renal parenchymal disease, no improvement despite stopping diuretics and volumes. What are the types? Type 1 and type 2. Type 1 is very severe, twofold increase in creatinine, 2.5 mg per dl in less than 2 weeks, and 50% drop in creatinine. Type 2 is less severe, associated with refractory ascites. Type 3, cirrhosis plus hepatorenal syndrome 1 or 2 superimposed on CKD or acute kidney disease. Type 4 is fulminant liver failure with HRS. New definition of HRS by ICA. HRS AKI, increase in creatinine more than 0.3 mg per dl in 48 hours, or more than or equal to 1.5 mg per dl from the baseline within 3 months, and other criteria. HRS and AKI. Type 1 HRS AKI, when GFR is equal to less than 60 for less than 3 months, plus absence of other causes of AKI. Increase in creatinine less than 50% of the patient value a value within 3 months. What are the causes? So, cause of uh, hepatitis syndrome, cirrhosis of liver, alcoholic hepatitis, metastasis of liver, acute liver failure, fulminant liver failure of any cause. Major pathophysiological Major pathophysiological mechanisms of HRS is hypovolemia plus splanchnic vasodilatation plus renal. HRS does not occur in primary biliary cirrhosis cholangitis. Reason is unknown. Bile salts retention. Other mechanisms: cirrhotic cardiomyopathy, systemic inflammation, hepatoadrenal syndrome, and cholemic nephropathy. Pathophysiology of HRS is liver failure, increased vasodilators, NO, PG, and CO, which leads to increased spinal vasodilatation, which leads to total vascular resistance and ABV and RAS, SNS, and AAP increase. So, renal hypoperfusion leads to renal vasoconstriction. To systemic inflammation is come to PIMP, DIMP, which leads interleukin 6, interleukin 8, TNF-A. Hepatorenal syndrome leads to cortisol production, decrease in HP axis dysfunction, and RAI and cirrhosis. Other mechanisms like cholemic nephropathy, bile toxic to tubules or structural tubules, which leads to AKI or HRS, raised IIP, which leads to renal hypoperfusion. So here you can see about by the pictures in this, and like actually the words are not expansion vasodilation leads to these things, portal blood fluid which leads to nitric oxide, prostaglandins, carbocarbons. So precedents of HRS is trigger HRS, bacterial infection, SBP, acute GI bleeding, and diuretic induced. Mainly the hypovolemia is the culprit agent behind it. So now, can I predict severity of HRS? Is very difficult, but why? In this, urea and creatinine is the poor indicators. Liver disease cause less urea creatinine production. Even creatinine of 1 to 1.3 can have GFR as low as 20 to 30 ml per minute. How can I diagnose HRS? Clinically, only the diagnosis of exclusion. No Swix test available. It should follow the HRS deficient criteria. DD of HRS in liver disease patients. HRS versus acute necrosis. Sepsis leads to ATN, which leads to pseudo HRS. GI bleed leads to hypertension, which leads to ATN. Antibiotics in CLD patients, which is aminoglipside, which leads to ATN. Analgesics in CLD patients answers to ATN. So, DD of the HRS in liver disease patients, HRS versus pre-legitimia, GI fluid loss, like large volume paracentesis, GI bleed, in case varices, diuretics, cause hypovolemia, and bilirubin-induced vomiting. Prevention: prevention of presents like infection, large volume paracentesis without albumin replacement, and since SBP. How to prevent this? Prophylactic antibiotics, SBP, and sepsis, albumin infection plus paracentesis. Management of this is on the medical drugs which we are using: TIPS, MRS, and RRT. Vasoconstrictors plus albumin plus reversing placement factors. Measures to prevent vessel bleeding: volume dilatation plus withdrawal diuretics. 20% of albumin 1 gram per kilogram per day for 2 days. Stop all nephrotoxins. You can see that acute increase in the creatinine more than 0.3 milligram per deciliter per dl. Increase the reason to fold lead to AKI 1A. Risk factors for management was monitors 48 hours. AKI 1B, albumin 1 gram per kilogram per 2 days. Increase in more than 2-fold AKI 2 to 3. and resolution. Urine biomarkers consistent with the ATN to RRT not available, non-diagnostic, consistent with HRS, vasoconstrictor, albumin. Albumin in HRS is in dose of 1 gram per kilogram per day for 2 days. Maximum dose is about 100 gram per day. And daily maintenance is 20 to 60 gram per day. When should I stop? Until the blood pressure is stopped or kidney functions, oblique kidney functions. Vasoconstrictions, we are using it like talipressine, noradrenaline, octreotide plus merodraine, vasopressin plus albumin. The guidelines and the facts about the talipressine dose about 1 milligram 4 to 6 hourly up to 2 to 4 to 6 hourly. Maximum dose is 12 milligram per day. When should I increase the dose? If kidney does not dose by 25% of the day 3. Should I give bolus infusion? Bolus in award settings causes more side effects. Infusion in ICU settings, less side effects with the side effects like ischemia, gangrene, peripheral, pulmonary-centric, and cardiac. Other vasoconstrictors are like noradrenaline. Dose is 0.1 to 0.7 mg 1 kilogram per minute. Target map is at least 10 mmg of increase. Octreotide plus merodraine. Octreotide, some testing neurologists, splicing constrictor. Merodraine, alpha 1 agonist. Dose maximum give for 14 days. Octreotide 100 MICS, subcutaneous TDS. Maximum dose 200 MICS SC TDS. Evidences. Which vasoconstrictor says strong evidence? Should we give albumin plus noradrenaline? When should other vasoconstrictor results? So, and these are some paragraphs in which on the evidence basis on albumin plus other vasopressors and on vasoconstrictors. I'm not going to detail of these tables. Other modulators like mass molecule absorbent circulatory system removes albumin bound toxins, TIPS, transnuclear intrahepatic portosystemic shunt. And important is that the transnuclear intrahepatic portosystemic shunt ultimately is the liver transplant or the kidney transplant. Plasma, sclisodonum, iothionium, cellexin, RHR2 in case phase 3 trial, and renal vasodilator plus RVR, decrease RVR, increased perfusion. Pentoxifalins, anti-TNF alpha, anti-inflammation, anti-inflamm, and alcoholic hepatitis. References are from ASLD guidelines 2012, ESL guidelines 2018, up to date, British Medical Journal, PubMed, Journal of Hepatology. So, what do you get the key summary from this thing? Important is that patient maybe suffer from cirrhosis liver at the time when there are many reasons, but we have already told you about that. If there is increase in the creatinine level as well, and the signs and symptoms of renal failure, in case it is acute or the chronic, mainly in the acute cases. So at the time we can easily tell that this is just because of hepatorenal syndrome. But the ultimate line of treatment is liver transplant because the liver functions are not working properly and the liver echo texture is altered. So now this topic is also covered, but the important point is that I want to say you something about that the use of albumin. The albumin, we are using albumin is a dose of 1 gram per kilogram per day, but the maximum dose is 100 gram per day. But if the patient is suffering from cirrhosis of liver at the time where the severe deficiency of albumin occurs, then the requirement of albumin is continuously required again and again to the patients, and which is if we think about the financial condition, that this is too much burden for the patient. So the main thing is to um, be take the measures which are mainly due to the prevention of the condition. Okay, thank you.